of tonight's presentation. Can everyone see the screen that I have presented for the presentation? I'll unmute everybody. Can everyone see the screen right now of the first slide, managing the needs of pediatric scleroderma patients?
Yes.
Good.
We can see it, but it's not in the regular PowerPoint mode.
Yes, yeah, I will put that in just a moment.
Okay.
With that, we're going to have people joining as we speak. And first of all, I'd like to welcome everyone to our every bi-monthly webinar. I want to say Dr. Casey. And how do you say your last name, Dr.
Torok? T-O-R-O. Yeah, Torok. It's Hungarian for the.
Okay. So I will turn over the introductions to Michael, and Michael will introduce you and give everyone else a bit of a background on your history. And so from that standpoint, and like I mentioned to you, Casey, is that doctor, is that once we start the presentation, just say next slide and I'll index the presentation for you.
Okay, sure.
Take it away, Michael.
Hello? Did Michael start speaking?
I'm sorry if for some reason I was muted. Michael, are you there to start this, please? All righty, I will just say I apologize as we've had just a few technical difficulties. As I was like to first thank everyone for joining us this evening, especially Dr. Casey Torok from the University of Pittsburgh and the Children's Hospital of Pittsburgh. Her dedication to this disease is uncompromised from the standpoint of that are willing to help out the children, and really is that the affected ones that we hear about the women and the men who obtain it, but it really is critical as the children are developing. I do not have your bio in front of me. I wish I could give you some more of an additional proper introduction, but Michael has that for some reason. He's having some tough technical difficulties on his end, but I'd like to introduce the doctor, and like I said, we can start the presentation.
Okay, excellent. Yeah, so for those who haven't met me, I'll give myself a brief introduction. So I'm Dr. Torok from the University of Pittsburgh Children's Hospital. I trained and stayed on as a fellow, like residency and fellowship here at Pittsburgh. So I've had a long-standing relationship with Dr. Metzger and Dr. Fagali-Bostwick, some of my mentors that were here at the university for quite some time. So I've seen adult scleroderma patients through the adult rheumatologist clinic as a fellow and kind of over time, and have started, my own pediatric scleroderma clinic and national registry that I've been kind of hosting for the last 9 to 10 years or so. So I usually am there at every national meeting for the patient education conferences. So if some of this material looks familiar and you've been at those meetings, some of it is kind of modified from my slides there. But the purpose of tonight, I was just going to go over general pediatric scleroderma. So that's both localized and systemic forms, which is a lot to do in 1 hour. So I had to truncate it the best I could to just general, what does this look like in kids, what's kind of different, pediatric onset versus adult, and then just a little at the end updates on research and treatment, and then I believe it's going to be open for discussion after that. So we can get started, and just stop me if needed. So, this is what is scleroderma. You guys know because you're here on the call, but a lot of people don't know, or your friends or family, so you have to describe what it is. So scleroderma literally means sclera is hard and derma is skin, so hard skin. This is an autoimmune disease. Your immune system kind of got overactive, and then it started attacking itself instead of doing its normal regulatory functions. The main two clinical types, as I mentioned, are systemic sclerosis, which is, if you just Google scleroderma, that's going to pop up more commonly. It's more common in adults. It's not very common at all in children. And localized scleroderma. This is also called morphia. So if you see a dermatologist, they call it morphia. You see a rheumatologist, they call it localized scleroderma. That's okay. They're the same thing. There's subtypes, but the overall umbrella term is similar. So even though these share some features with skin pathology, they are distinct diseases. They have different effects on the musculoskeletal system and the organ system. So we're going to go over that. And importantly, I wanted to mention, because this is a very common question I get from parents when they see me, if their child will develop the other form. So most of the time, this is parents children localized or morphia, and they're concerned that they might develop the systemic scleroderma type, and that is highly uncommon, like 0.01%. So the answer is pretty much no, once in a blue moon, but not very often. All right, next slide. So just a brief overview. This is in the autoimmune disease category. So same as rheumatoid arthritis or autoimmune thyroid disease. It's basically your immune system, which is supposed to protect you from viruses, gets triggered by a regular virus, just normal everyday encounters. And instead of kind of going back to neutral after it fights that virus or whatnot, it kind of stays on and it gets a little confused, and that's when it starts causing some inflammation and sending inflammatory cells to the skin, to the fat, the blood vessels, and things of that nature. So over time, this inflammation starts collecting in the skin and other organs if it's systemic scleroderma. And that inflammation then eventually can start causing these cells called fibroblasts to start depositing collagen, which kind of develops that thickened skin feeling or thickness or fibrosis. So it's kind of both inflammation, and then that kind of leads to fibrosis or thickening. Next slide, please. So that's what kind of connects the two, is the collagen or the fibrosis. So this is just a picture, a visible histology picture, if you would biopsy the skin, of what this would look like. As I described, the early changes is more of the immune system, those immune cells, all those purple cells in the middle of the skin, those are lymphocytes. So those are your immune cells kind of attacking the skin and around the blood vessels, etc. Then the later skin changes, those inflammatory cells, the lymphocytes and things, they mostly go away. There's a little, but they mostly go away, but they leave that thick pink collagen that you're looking at, or that thick skin, etc. And then sometimes they, quote unquote, for better terms, like eat away the skin, so the skin is left with like a depression. It's a little bit what we call atrophic, so it's kind of thinned out. So kids that should have normal, healthy, like firm skin might end up almost having kind of like shiny, old lady looking skin in the affected areas. Next slide. And this is just a slide showing a brief caption of the difference in kids for localized versus systemic scleroderma. The incidence of localized is still uncommon. It's 3 in 100,000 kids, but that's as common as pediatric lupus and things. But pediatric systemic sclerosis is extremely uncommon. It's 1 in a million. When I did the population estimates, I think there's maybe 300 or so kids in the USA with systemic sclerosis. It's not common at all. The localized pattern is typically like a unilateral band, down the arm or leg or the face. It can be different, but that's kind of the more typical distribution. And then it does have what we call extracutaneous or beyond the skin changes in a fair amount of patients. Some degree of involvement of joints or bone. They may have limitation, range of motion, almost like arthritis. If there's a linear band over their face, they may have some brain or eye involvement, etc. Flipping over to the systemic sclerosis panel, the skin is a little bit different. The involvement is typically kind of more widespread, not just a linear band. It's kind of the fingertips and then moves in up the arms, like towards the chest, and the same thing with the lower extremities. And Raynaud's phenomenon is very common. 90-some% of the patients have the finger color changes. I'll show you guys a picture in a minute, but with cold exposure or stress. And this got cut off a little bit, but the extracutaneous manifestations in systemic sclerosis are, very, very common, about 90%, and involves the joints and muscles, but more so the internal organs, such as the GI tract, the lungs, the heart, rarely the kidneys. So that's the main differences between those two. Next slide, please. All right, and this is just a picture, a visual of a more typical localized scleroderma pediatric onset patient I will see. As you see, her arm has a linear kind of band down it, traveling kind of on the underneath side under her elbow, and then extending to her fourth and fifth fingers, and her fifth finger is actually kind of tacked down on the left. And that's when she was younger. The pictures on the side with the blue background are when she's older, and it actually affected the other hand. If you can see on her right hand over her thumb is affected as well. And then when she flips her hand over, you can see the damage that remains from that left hand involvement, that her hand is, or wrist is kind of altered, and that's, kind of affecting some of her mobility. Next slide. And this is a pediatric patient with systemic sclerosis, onset around 5 years old or so. And this is the quote-unquote look of systemic sclerosis, where you have a thin, tight upper lip. The face may look pinched or pulled around the nose. The skin is often a little thinner. You don't see it in this patient as much, but you can have a lot of visible veins on the neck and the face, and sometimes hyperpigmentation around the neck. And then the fingers, this is a little, at this point she's 7 or so. This is a little 7-year-old. Her fingers should not look kind of tapered like an older person's fingers. They're kind of full and tapered, meaning that they're kind of fat or swollen at the base of the finger, and then they kind of taper down to a more thin, kind of triangular at the tip of the fingers. And then she flips her hands over, and you can see that she has digital ulcers from recurrent Raynaud's. So the skin's not getting the blood it needs to. It makes an ulcer on the tip of her thumbs and some of her fingers. So that's the typical area where those digital ulcers will happen in systemic sclerosis. So those are just 2 example patients. And then here's just some more information about who gets juvenile onset scleroderma. Girls a little bit more than boys, but not to the extremes we see in the adults. It's relatively even-steven. It's maybe 2 to 1 girls to boys. The mean age of onset for this is around 8 years old for either condition in pediatrics. But for systemic scleroderma overall, it's more common. 40 years of age is the average age of onset. But within pediatrics, it's around 8 years old. But we do have some children that are very young at onset. So far, we're seeing in these cohorts across Europe and Canada and the U.S. More Caucasian predominance. There's actually in localized scleroderma. We don't know yet in systemic scleroderma because it's so rare. There is an international cohort that I work with, my colleague Yvonne Foldavari in Germany, and it still seems we have maybe 100-some patients in that cohort. And even though it's pulling from Japan and China and everywhere, it's still a Caucasian predominance a little bit with the systemic scleroderma patients as well. Diagnosis is often delayed, as in children, some of these signs can be very subtle, or, just it's uncommon, so they'll go to different doctors until they actually see the pediatric dermatologist or pediatric rheumatologist. So it's about a year or so delay of these conditions. Next slide, please. So how it's diagnosed, I think everyone wants to say it's blood work, but it's actually not. The blood work is kind of supportive, the labs. The best thing for the pediatric rheumatologist, whether it's juvenile arthritis, scleroderma, lupus, is actually your history and physical exam. There's certain clinical features that gives you clues to what's going on, and the history or pattern of problems that's happening in the patient. They're the most helpful. The blood tests are helpful in kind of putting things together, organ screening, things like that. But it's not like if you have a positive ANA, that doesn't mean you have to have an autoimmune disease. But obviously, if it's supportive, a certain antibody supportive in clinical features, then that would make sense. Next slide. So skin features, I put both pictures of localized and systemic sclerosis patients on some of these slides, so I put little indicators on who's who. But in general, both will have kind of increased skin thickness. It just depends if it's more, focused on an area in localized scleroderma or more diffuse in systemic sclerosis. And in systemic sclerosis, you get this term called sclerodactyly, which is kind of like edema or swelling of the fingers and then thickening over the fingers as well. And then eventually kind of there's shiny and smooth. The picture of that, the girl on the top is her trying to bend her fingers down, and you can see they get really pale and everything because that skin is really taut and stretching over her fingers. And she can't put her fingers all the way in her palm. A healthy, unaffected person could do that. There's some color changes we look for in active disease, specifically I'm talking about localized scleroderma. You'll see like a rim of erythema is what we call it, or redness, or a violaceous or purple rim. And you'll see like a waxy yellowish white center that's thick. That's usually kind of active or newer lesion. And then other pigment change that can happen after the disease calms down or is treated. You can see what we call post-inflammatory or after inflammation hyper or hypopigmentation, and that's seen in both conditions. Sometimes it's a little more apparent in African Americans. That's why I did the picture of my patient on the bottom with the blue shorts. So she has dyspigmentation or hypopigmentation, low pigment over her knuckles and some areas of her fingers, and she has systemic sclerosis. Next slide, please. Other skin features are kind of thinning of the skin. As I mentioned, the skin can look kind of shiny or visible veins, like kind of old people skin in a young person. And the top upper corner with the yellowish background, that's what we call cliff drop atrophy. It looks like the skin just kind of drops off, that type of atrophy. There is the type of atrophy that there's no subcutis or fat left. The patient with the linear involvement of their whole entire leg, the fat is pretty much, almost gone in their calf. And then there's also specific changes that go more with systemic scleroderma, such as telangiectasias, a picture from the textbook. And that you can see that patient, that little boy, also has the thin upper lip that is, again, more classic with the systemic sclerosis. There's calcinosis deposits with the girl with the blue background. That's calcium kind of extruding from near her joint, but that can happen kind of any areas of contact. The other finger pictures, digital ulcers that are kind of healing and kind of change the configuration of the finger in a patient. And the lower picture is kind of the blue-purple discoloration with Raynaud's and the starting of some digital ulcers that are forming on like the index fingers of that patient. Next slide. So this is now going, so those are just common features or different skin kind of features that we look for on our exam. Now I'm going to talk a little bit more about localized scleroderma and the subtypes, and then I'll talk about systemic sclerosis and the subtypes. So localized scleroderma, again, is more common in kids than the systemic. This is usually in the linear pattern. The linear pattern can involve either the head, and sometimes that's called in coupe de sabre. If it looks more like a sword of the saber, that's what that means in French, like a line. That's that girl with kind of the line almost straight down the middle of her forehead. And then sometimes it looks more like what they call peri-Romberg, is another name for what they call hemifacial atrophy, or half of the face is smaller. So that's the young boy with the yellow sweatshirt. He has peri-Romberg on that one side. But then I have a fair amount of patients, and this occurs at different registries as well, that have a little bit of both. The patient from the middle is taken from the website, American College of Rheumatology website. That's why he's de-identified, and you can see his eyes. But he has an in-coupe type of lesion because it's like a linear band with some what we call alopecia or missing hair on his scalp. But then he also has the left side of his face is smaller. So that's a little more what we call hemifacial atrophy. So he has kind of features of both. And that's why we kind of clump these all together, because we feel they're all in the same spectrum. Some people split hairs and will call it either one or the other thing, but honestly, it's all related. And then you can have linear scleroderma of the extremities. So that's the young lady at the top of the slide. She has linear band down her leg, and sometimes that can cause decreased range of motion if it crosses a joint. So those are the main types of linear scleroderma. There's also what we call circumscribed, or kind of like more well-defined plaque lesions. So they can be superficial, meaning more on the surface. That's the young lady with, you can see like whitish neck lesions. They're kind of white around her neck. And then there's a deeper version where you don't have too many changes on the surface, but it's kind of looks like a scooped in lesion. Typically this is on the buttocks, the hips, the trunk, kind of the abdomen area. So that's the corner picture. Next slide, please. And the other types of localized scleroderma are mentioned here. So you can have generalized morphia, so that's multiple plaques kind of happening all over the body, typically surrounding around the trunk, which is like the abdomen, chest, but then kind of creeping onto the extremities as well. The upper corner picture is a Caucasian patient with this generalized plaque morphia, and you can see those plaques are kind of what we call coalescing together to kind of unify with some, you can see discoloration throughout. The lower right corner is an African-American patient with the generalized plaque morphia, but she has some sparing areas, but it's just kind of in the center of her belly. The patient on the bottom that looks very kind of swollen, a lot of edema, shiny skin, this is a patient with pansclerotic morphia. This is extremely rare. I literally only have a few patients out of my 500 in my cohort with this, but it's basically involvement from the top of the skin down to the muscle, and then all around the extremity and the trunk. So not just on one side of the leg, it's kind of circumferential is what we call that, all around the leg. So that can cause a lot of swelling and pain and stiffness, almost like systemic scleroderma. This can be confused for that. And then mixed is just you have two or more forms. Typically this is like a linear band down the arm, and then maybe some generalized plaque morphia on your chest or abdomen. That's the most typical mixed picture that we see in pediatrics. Next slide. Systemic sclerosis. These subtypes are from the adult scleroderma subtypes, and they are reflected in children as well. So if you've gone to any of the Scleroderma Foundation meetings and you hear them talk about diffuse or limited, the same classification applies to kids. It's just a little bit different as far as the frequency of this in children. So the diffuse cutaneous is basically the skin's thickness starts at the tips of the fingers and tips of the toes and kind of works its way in towards the center of the body. This type, I have a little figure on the side, does have lung involvement, potentially kidney involvement, etc. So interstitial lung disease, scleroderma, renal crisis, things of that nature are of risk with this subtype. Limited cutaneous is very similar. It starts with that skin thickening distally, which is moving towards the center of the body, but it kind of stops at the elbows and the knees. That's why that person's shaded. The gray shading on the skin kind of stops right at the elbows and knees. So the skin is actually directing this terminology of limited cutaneous. These patients typically have Raynaud's, telangiectasias, calcinosis, GI involvement, and then they can also be at risk for the pulmonary arterial hypertension or increased blood pressure of the pulmonary system. This is pretty rare in children, to be honest. We have more of the diffuse cutaneous, and then we have overlap. About a third of the kids actually have overlap. This is different from adult. Adult maybe only have 10% of their patients with overlap. What overlap means is that you fit the criteria that we as rheumatologists use through the American College of Rheumatology for scleroderma, but you also actually meet criteria for dermatomyositis or lupus. The patient will have typical skin manifestations or muscle involvement that would make them be classified as dermatomyositis, or they might have lupus features, either skin or lupus nephritis, something of that nature. So this is more common in children. The most common kids that I see with this start with Raynaud's, with nail fold capillary changes, digital ulcers, myositis, and arthritis. Sometimes they're called dermatomyositis for a while, but then it becomes more apparent that they're truly an overlap patient. So I think this is becoming more clear, and I'm trying to spread the word that this is, truly the overlap type of systemic sclerosis. Next slide, please. And then I think I kind of mentioned this as I was talking about it, the difference with localized versus systemic as far as adults. So with localized scleroderma, going back to the subtypes, linear and mixed are more common, as I mentioned, where the adults, actually the circumscribed or kind of the individual lesions or plaque morphia on the chest or trunk is more common. The prognosis in the kids compared to adults, not compared to systemic sclerosis, but compared to adults, is a little bit worse. And why I say that is because this linear band or pattern happens when the kid is developing. So they have more potential to have some limitations in their musculoskeletal functioning, if they have limb length discrepancy, so one leg maybe an inch or two shorter than the other leg, or a joint contracture limitation, or if their face is involved, if the face develops and it's smaller than the other side that's affected, which does not happen in adults because adults are already fully formed. So if they get this condition when they're adults, it's not like it stops their legs from growing or whatnot. So that's why it says a prognosis a little worse compared to adults. For juvenile systemic scleroderma, actually the opposite is true. The prognosis is much better than the reported literature in the adults with systemic sclerosis. So that is reassuring. There's been more recent cohort studies with CARA, the Childhood Arthritis and Rheumatology Research Alliance, which I'm like one of the leaders, as well as Yvonne Foldavari's Inception's international cohort that's showing, good survival and no major, the patients once they're treated are relatively stable without a lot of development of new organ manifestations. So that is looking better over time. Next slide, please. Lab testing, again, I just wanted to explain it because I think this may be a source of confusion. If I was a patient, I would not understand this fully. But basically, a lot of the times when the doctors talk about ordering antibodies or whatnot, the main screening one they'll use is an ANA, an anti-nuclear antibody. This is commonly positive, I would say 95% plus in systemic sclerosis. Localized scleroderma, about half the time, about 50%. An ANA itself is nonspecific. You can have that with autoimmune thyroid disease. You can have that if you're healthy. 5 to 10% of the healthy population has a positive ANA. But if you have that, you want to go ahead and see if there's specific, what we call extractable nuclear antigens that would kind of explain the ANA. So that's in the case of systemic sclerosis, you want to check for SCL70 or centromere antibodies, polymerase. The names aren't so important. It's the fact that, we're checking for additional antibodies that might help kind of steer the clinician towards a particular subtype or diagnosis of systemic sclerosis. And they do have some organ manifestations with them, like U3-RNP has a little more myositis and potential cardiac involvement, etc. So it just makes us screen a little bit more for those certain things. General labs, if your child has this and they're getting typical labs, typically their SED rate and CRP is not going to be through the roof, not going to be super elevated, might have mild anemia, muscle enzymes might be a little elevated. These typically aren't shocking traditional lab abnormalities. Localized scleroderma is the same way. You might have some muscle enzyme elevation or a little bit of inflammatory markers, but it's not through the roof, not like some of our other diseases like lupus where the SED rate is real high. There are some antibodies that go along with juvenile localized scleroderma that are a little more specific, like histone and single-stranded. Again, seen in about half of the patients. So if the patient's negative, it doesn't mean they don't have it. It's just a marker that we kind of follow. And skin biopsies are definitely helpful if the diagnosis is unclear. Sometimes things might look like lupus or dermatomyositis versus scleroderma, so they are helpful in certain cases. Next slide, please. And then other evaluation. Again, I'm just kind of clumping localized and systemic scleroderma to make this talk within an hour, but other imaging that you can employ, ultrasound, you can look at that with the skin and subcutaneous tissues or joints to see if there's arthritis. My colleague Suzanne Lee has published on this and does this a little more routinely, but sometimes it does help if you have a localized scleroderma, you want to see if the lesion is a little active or not. It does take some time and a dedicated ultrasonographer. MRI, that is helpful if you want to see the depth of the involvement. If you think there's some involvement of the fascia, that's the layer between the fat and the muscle involvement, etc., and joint involvement. I wrote MRI of the brain. We typically do get this as a baseline screening for any of the patients that have the involvement of the linear scleroderma of the head. And then x-rays and CTs in certain situations. So in systemic scleroderma, you would want a CT of the chest to look for interstitial lung disease. But otherwise, it's a case-by-case basis. 3D imaging can be helpful for monitoring the face in the linear scleroderma of the head. I'll show you a picture later. And then other studies that would be used, again, a little more for the systemic sclerosis would be pulmonary function tests, and I'll show a picture of that later. For lung function, echocardiogram, EKG, cardiac MRI, GI evaluations with things like swallow study with speech therapy, upper GI and small bowel follow-through, and then sometimes endoscopy or gastric emptying scans. For either condition, dental assessment is good for anybody, any kid, but specifically patients that have involvement of the head with the linear scleroderma or systemic sclerosis actually can have gum atrophy, dry mouth, get cavities, things like that. And the slit lamp examination is good to screen for uveitis, again, a little bit more for the patients with the facial involvement with the linear scleroderma. Next slide, please. This is an example I was mentioning about ultrasound and localized scleroderma. Like I said, it can be helpful if it's unclear. This is a patient of Dr. Lee's. She let me borrow it from New Jersey. So she was following this patient who has linear scleroderma down her pinky finger, and she treated her, was inactive, quiet, and then the patient started saying, hey, I'm starting to have a little pain. This is getting stiff. But Dr. Lee didn't see any objective signs of disease activity. It wasn't red. It didn't look like it was expanding, getting larger, no new areas. The range of motion was preserved. So they did an ultrasound and compared it to the fifth finger on the unaffected side. So you can see the top panel when you compare the unaffected fifth finger to the affected, that there's more of this Doppler, which is just the blood flow is higher. That just means there's more what we call hyperemia or inflammation going on there. Then she treated this patient, I believe, with methotrexate, then did a repeat ultrasound and showed that the control finger was the same as the affected finger, so that inflammation went down. Next slide, please. MRI can be helpful, as I said, in certain instances. This is MRI looking at kind of like a deeper involvement. So patients with linear scleroderma with deep disease or deep morphia, this can definitely be helpful, especially if they don't have too many skin changes on the top to help monitor disease activity. This was a nice study in 14 juvenile localized scleroderma patients. And you guys can see this rim where the arrows are pointing, rim around, that's called the fascia. That's like the encapsulated layer around the muscle. So fasciitis is inflammation of the fascia, and that's a sign of active disease. So we'd want to treat this patient and then, monitor them. So we've been using this a little more often in kind of deeper disease to help monitor. Next slide. This is a 3D facial imager. I just thought I'd put a picture because it's hard to describe to people. But basically, there's no radiation. It's literally a camera, but it's just taken from standardized angles, and then the computer puts these 3 pictures together to make a 3D mold. So in reality, I work with the craniofacial surgeons, you can just kind of rotate in the computer, rotate this shell of a face. The helpful thing about this is that's your baseline picture. Then the patient with the linear lesion on their face comes back 6 months later, you take the picture again, and then you use certain points, like the tip of the nose, tips of the ears, and then line those 2 images up, and then the computer software will overlay the 2 and tell you if the skin has gotten deeper or not. This has animation, so if you just hit like the next couple clicks, it should go. Yeah, so that's a patient that had fat grafting. So the before is before fat grafting, after is after. And then the 3D imager picture with the heat map is the 2 on top of each other, showing that and can you hit the mouse 1 or 2 more times? There's little circles that pop up. So the fat was injected into her lower right chin and then her left face. If you just click the mouse 1 or 2 more times, those circles will pop up.
Doctor, let me just ask, first I've ever seen of this, is this very well commonly used right now in the United States?
This is more on a research/clinical basis, but only in a couple centers. I'm actually piloting a handheld one so we can get them at more centers. But craniofacial surgeons have them to monitor cleft palate repair. Mm-hmm. Okay, there you go. Oh, well, that's okay. The circles are just showing where the fat grafting went. So the blue meant the fat was coming out. So localized scleroderma, the crux of this talk was kind of like, okay, what's different in kids from adults? What do we need to monitor for? So this is the main thing, is as I was kind of honing in on, is the linear involvement of the extremities is the most common subtype. So we worry about the musculoskeletal involvement the most here. And you can see the girl in the lower panel. This is one of my patients. She has about a 2.5 centimeter leg length discrepancy of the affected left leg. The girth of the left leg you can see is a good 4 centimeters, or that's like maybe 2.5 centimeters smaller in girth. So, as she matures and grows older, this is making her more self-conscious. When she's kind of waitressing or whatnot, it's bothering her because she has to kind of stand funny and it hurts her back at the end of the shift, things of that nature. She does have a shoe lift, and we actually did have orthopedics try to interrupt the growth plate on the unaffected side, but to slow it down so it wouldn't be so discrepant, but she still has a pretty significant change. So that's like a real life example. The example on the top, luckily we don't see that often anymore because we're pretty aggressive about starting treatment, methotrexate or Celsep and steroids. So this is from the American College of Rheumatology bank, but obviously you don't want this to happen where there's a full contracture of all of the fingers of that left hand, just from the fibrosis that was not like aborted or modified. And so a lot of these patients, even if they don't have extreme limitations like that, they'll still feel like a tightness. Sometimes there's like a deeper band like you saw in the MRI. So they might have what we call myalgia or muscle pain. Sometimes they have muscle atrophy or loss, which you see in the picture with the girl with the smaller girth of her leg. And then, as I mentioned, you can have joint limitations or joint range of motion issues. Arthritis is pretty uncommon. Frank arthritis, like swelling of a joint, like we would see in juvenile arthritis or rheumatoid arthritis, but it does occur. Next slide. And then, again, growth problems. This is more unique in pediatrics than adults because adults have already grown. So when the kids get this, especially, certain areas, you definitely notice some cosmetic effects or growth differences. So you can get undergrowth of the affected side. The head lesions causes hemifacial atrophy, which you can see in this patient, which is quite significant. The arm or right leg can be thinner or the entire limb is shorter. The patient on the upper corner, if you can pay attention that his right arm, like his whole actual scapula is smaller and his bicep area, et cetera, is smaller. The picture kind of in the middle that's kind of fuzzy, that's from the American College of Rheumatology website as well, and that we really don't see that much anymore, but that's really sclerotic, missing muscle, et cetera, kind of joint limitation as well, that poor little guy's shoulder. And then the frequency, as I mentioned, is relatively common to have some undergrowth or growth problems with an extremity. About 22% in a recent localized scleroderma study in a research group that I'm a part of, and then about 50% in a more recent study that we did through CARA. And then sometimes the growth difference is actually not obvious until later. This is especially for my patients with the linear involvement of the face. It might be pretty subtle when they're like got the cute little chubby cheeks when they're 4 or 5, but once they start to become 10 or 11 or 12, you start seeing that as the face matures, you can see that one side is a little smaller than the other, a little more obviously. Next slide, please. And then just things to look for again. Neuropathy is pretty rare, but it happens. So patients that have very bound down skin, this is what I'm talking about, is usually extremities like the carpal tunnel, or the patients with that pansclerotic morphea or the systemic sclerosis in the beginning. You just have so much edema and swelling of the skin and the fat underneath that sometimes the nerves just kind of get compressed. Usually once the edema part goes away, that gets better. And then the next things that I'm going to mention are specifically for patients with the localized scleroderma involving the head. So that's when you can get hair loss of the scalp or eyebrows or eyelashes. You can have oral problems or dental issues, such as the young man at the top, where he has an obvious what we call dental cant, where his whole jaw is kind of going to the side. Sometimes the roots of the teeth are atrophic, like the little girl in the middle. She has that linear band down her gums, and then she has what we call an atrophic root, so the gum is kind of missing. So unfortunately, if that baby tooth falls out, the adult tooth might not have a root. And then you can have a smaller tongue, but usually that doesn't cause any issues, usually no eating issues, so that's good. But the brain involvement is something we screen for, as I mentioned. It can be a variety of things. It can be total normal brain MRI, which is wonderful. I would say maybe 20% there's an abnormality. Sometimes there's these just little white matter lesions, but I'm showing you a picture of something more significant. You guys can see that, the right side of the brain has those kind of white lesions that should not be there compared to the other side. And this is on the affected side of the skin as well. And this is the patient's skin and the groove. She actually has like 2 grooves in this area on the right side. Some patients will have seizures. That's not common, or inflammation of the blood vessels of the brain. Again, that's not common either. Eye problems can be uveitis, which is inflammation of the eye. That's seen in juvenile arthritis as well. Rarely decreased vision. That has to have like long-term uveitis to cause that. Dry eyes is pretty common, especially if the linear lesion is somewhere near their eye and they're not shutting their eye at night all the way. Sometimes they'll need to do like lacquer lube or something on the eyes to help that. Next slide, please. All right, and so I just wanted to hone in that scleroderma is a chronic disease, and that's true for most autoimmune diseases we treat. But the course can be variable. Some people have more mild disease. Some people have more remitting and relapsing disease. Some have very active, just hard to control. Most patients will fit a pattern of, what we call remission. So you treat them, they'll respond, they may be in remission, but they may flare later down the road.
I can't hear you. We can hear you. You're not on mute.
So our goal is to treat, to minimize the disease impact. So hopefully some of those pictures that you saw of like the disease damage and things, we want to minimize those things. We want to do that by controlling inflammation, get them moving, do PT and OT, things of that nature. If we can get them off medications, wonderful. But our goal is remission, that the disease is quiet. We don't see new lesions, we don't see active lesions, we don't see advancement of the disease. And then obviously there's some things that, if it's GI involvement in systemic sclerosis, there's certain things we can do, but there's not an exact medicine for that yet. We kind of had to improve function and help with their discomfort, and there's some other measures I'll go over. But the biggest thing is we want these kids to be kids, go to school, do their sports, try to get as best we can towards normal growth and development. Next slide. And I think this is actually a little, I wrote localized scleroderma, but this can be both. You know, in both conditions, we're a little bit better at treating the inflammatory stage rather than the fibrotic stage. So all of our different medicines you'll see in the next slide have better effect on the inflammatory infiltrate that you guys saw earlier, those lymphocytes and things like that. Supportive care is great for the skin, whether it's localized or systemics, and lots of emollients, protecting against the elements as best as you can. Sun protection's great. It's not 100% necessary. The sun does not flare this disease like it does in lupus, but it can just kind of make that hypopigmentation stick out a little bit more. Physical therapy and occupational therapy are key. Definitely if you have localized scleroderma that crosses a joint, you have stiffness or tightness, and in systemic sclerosis, you know, most people do have limitation of fingers and things, and that's great to do the OT and PT. Next slide. So this is what I was mentioning. There's kind of a list of medications. So the go-to medications for localized scleroderma, when I say moderate to severe, because we typically wouldn't do this if there's like maybe 1 or 2 small patches on the abdomen. You might start off with topical therapy and monitor. That's totally appropriate. But if you have a patient that has, you know, the linear down their arm, down their face, you know, lesions that are about to cross the joint, you know, you would want to consider, you know, methotrexate and steroids have been kind of the crux of our treatment. More recently, we're using CellCept or mycophenolate mofetil, MMF, as a kind of alternate to methotrexate. We still need to do an actual clinical trial with that, but we're kind of using that more and more. We've adopted it from the adult systemic sclerosis folks and have found, at least clinically, it's been just as effective as a methotrexate. Plaquenil we've seen used. We're not 100% sure how much that works, and there's a list of others, but some that are becoming a little more popular because we're using them in juvenile idiopathic arthritis are the biologic agents. So these are typically injected once a week or once a month IV. Orencia or abatacept and Actemra, tocilizumab are becoming a little more popular to use. Typically, it's for the more refractory cases that aren't responding to methotrexate and or CellCept, but we are considering doing some studies as a first-line therapy as well. And Cytoxan can be used in like pretty, you know, pansclerotic morphea or very significant disease. And if you just want to click, I think I just write more details to come. Yes, okay. So other treatments for localized scleroderma, if you have some joint pain or muscle pain, NSAIDs are fine. Typically there's no kidney involvement like lupus, etc. Topical creams or ointments, again, are great for the mild superficial lesions. They may help out a little bit, but should not be your mainstay if you have a huge linear lesion going down your leg. Phototherapy is helpful. I would have to defer to my dermatology colleagues. They use this a little bit more in adults. In kids, they're a little more refrained from using this. That they use UVA-B, I believe, in kids a little bit more. This is helpful, but usually the more superficial types. So if you have like a deeper involvement, it's not going to get to that fascia layer, things like that. So that is a consideration. So surgery would be if you would need fat grafting for the facial involvement. This young man had fat grafting at my center, so he has a divot, as you can see on the left side of his face from the hemifacial atrophy. And then fat grafting is just taking fat from your butt, spinning it down, purifying it, and then put it in little tiny droplets in the affected area, and then you can see it filled out quite nicely. There's surgeries for the extremity involvement. If you have, a joint that's contracted, that means kind of stuck, they can do tendon release. We talked a little bit briefly about the leg length difference. You can kind of pin the growth plate of the unaffected leg, things like that. Next slide. And then, so what problems happen in juvenile systemic sclerosis? Again, that's another hour-long talk in and of itself, but I'll try to kind of just summarize it in a few slides here. This is a multi-organ involvement disease where you can see listed, many organs can be involved. So these are general clinical features are similar as far as like interstitial lung disease and gastroesophageal reflux, things like that. But the frequency and the severity tends to be different than adults, typically in a good way, usually less severe and less frequent. Next slide. So again, these are just more pictures of patients with systemic sclerosis, and I just think pictures are helpful so you can see what we're talking about when we talk about these things and what we're looking for. And in kids, sometimes it's subtle. The patients on the bottom, you may not truly appreciate it, but they have telangiectasia. So the one girl has telangiectasia across the bridge of her nose and her cheeks. She's the one that had that big calcium deposit in a prior picture. The young man with his mouth open actually has telangiectasia on his lips. The camera is just kind of hard at capturing that. The picture of the patient in the upper corner you saw before, that's African-American female with systemic sclerosis with a pigment change. If we zoomed in on her nail fold capillaries, they're very abnormal, and her cuticles are very thick. And then the young girl with the kind of tapered fingers and the fuller fingers on the bottom. So those are just some skin changes we talked about. But again, a little more subtle in kids than the classic textbook that you might see online for adults. Next slide. So vascular problems. This is definitely more in systemic sclerosis. You might have Raynaud's and localized scleroderma, maybe 10–15% of the patients, but they typically will not have the other things that go along with this, such as the nail fold capillary changes or the digital pitting ulcers. This is more indicative of the systemic sclerosis. So, you can see the big digital ulcer on the bottom. The patient, both her pointer finger and her thumb, and the patient in the middle, it's hard to see, but she has purple-blue discoloration of her fingertips, and she has some active digital ulcers on her middle and pointer finger. And then the Raynaud's is that triphasic color change where this is very classic off the internet. The young man at the top of the screen where his fingers have that paler or white, and that's it just stops at certain areas. That's very classic of Raynaud's, and then that's very painful. That's ischemia. That's the fingertips not getting blood. You get that under hot water. It reperfuses, turns red, but that hurts too because your fingers are now filling with blood. And then the nail fold capillary changes example is a picture in the corner. That is seen about 70% of the patients with the systemic sclerosis, but that is pretty indicative of it. A healthy person may have Raynaud's, but typically they won't have the digital nail fold capillary changes or the digital ulcers. The other type of vascular involvement is pulmonary arterial hypertension. So that's the increased blood pressure in the pulmonary system. Typically this is rare in kids, maybe 2 to 13% max, but 2 to 5% in more of the recent cohort studies. So that we are thankful for. Next slide. Other lung issues would be, besides pulmonary arterial hypertension, we just talked about that, but an echocardiogram is a decent way to screen for that. Another way to screen for that is on the pulmonary function test. But the pulmonary function test is a little bit better for screening for interstitial lung disease. So that's where you get inflammation in the lungs themselves. And then that inflammation can cause that collagen to deposit and just like the skin to get fibrotic. So this is actually a picture of a young girl. She's about 7 here that has interstitial lung disease. And so her CT scan is on the bottom, and that's basically a cross-section. Her heart is the big globular thing in the middle, and those Lung fields on the side should be nice and clear, but you see there's definitely areas in the front and the back and on the sides that have that kind of ground glass kind of presentation to them. And then other things to do, we just talked about the pulmonary function test. I'll show you a picture of that next. Here you go. So this is hard for a kid. So when we get this on a 5 or 7-year-old, we kind of take it with a grain of salt. And the picture on the top doesn't show you, but this child is actually in like an enclosed glass space. That's the best way to get this DLCO, this diffusion lung carbon monoxide level. This just lets us know how the lungs are exchanging oxygen across the pulmonary beds. If there's pulmonary arterial hypertension or interstitial lung disease, the DLCO will be decreased. But unfortunately, this is a very tricky number, and you really need the pulmonologist to help you interpret this because there's a couple of things that go into these calculations, but they're very helpful to follow over time. So that's what a pulmonary function test looks like. Next slide. Other things we do, GI involvement can be anything from the mouth to the anus. So there's this whole laundry list of things that can happen in systemic sclerosis. Basically what happens is the peristalsis is off. So instead of food going from the top of your esophagus, bottom esophagus, stomach, small intestine, large intestine, it kind of goes back and forth a little bit. We hypothesize, who knows, there's some kind of neuropathy or some reason that the GI system is not kind of giving the right signal to go down correctly. This can cause some dilation of areas of the GI tract. It can cause GERD or gastroesophageal reflux disease. That's the most common. That's like 60–70% of the patients. Dysphagia or trouble swallowing or feeling like you're getting something stuck. Gastroparesis is kind of food just sitting in the stomach for a long time. So there's different radiological ways you can evaluate this, and some things are with speech therapy and seeing how you swallow food, etc. And on the side, I have more recent survey of the systemic scleroderma patients in our CARA cohort and kind of the percentage that was documented. And that's a little low, probably 42%. I bet you it's more, but it's just how the data was captured. And there's more specific GI testing, but I tend to prefer that these patients go to a GI motility specialist if they're going to have the manometry test or the pH probe, etc. Next slide. So musculoskeletal, you can just click all of these because they're all pretty similar. So musculoskeletal is the similar to adult as far as like you're going to have a little bit of bland myositis, some mild arthritis, but it's more common, about 30–50% in kids. They can get weakness and atrophy, etc. Cardiac and renal, fortunately, in pediatric systemic sclerosis are very rare, but obviously we want to make sure that we're aware of it, we screen for it when necessary, because it can have bad outcomes, of course. So there's certain antibodies that we might associate and be a little more strict about our screening. In general, we ask our patients to get an EKG or an echocardiogram. If we suspect something else may be going on, you know, we might add a Holter monitor or cardiac MRI and talk to the cardiologist. Renal is very, very, very rare. Luckily, in our recent CARE cohort over the past like 3 years, we've not had one patient with scleroderma or renal crisis, and very rarely have any cardiac involvement. You can go to the next slide, that's fine, because that's the CARE cohort, just showing longitudinally, so orange is the baseline and blue is like 1 to 2 years later. And if anything, we didn't see, the bottom line for this is that we didn't see an increase. We didn't see all of a sudden there was a 10% jump in pulmonary events or GI events. It seemed like these patients were relatively stable. These were not new onset patients that were enrolled into the registry. They were just anybody that the pediatric rheumatologists across the nation had in their clinic. So some of them were new, but some of them were patients that have been followed for 4 years or so. But in general, you know, this we felt was good. It looked like dermatologic, so the skin score may be improving, the Raynaud's may be improving, overall, the frequency of musculoskeletal, GI, and pulmonary issues were the same, and renal and cardiac very low. And those cardiac that were on there are actually just some mild EKG changes, but nothing clinically significant. Next slide, please. So management, again, like I was mentioning in localized scleroderma, a lot of supportive care, occupational physical therapy, keep the skin nice and moist. Brain gnaws is kind of different, right? You want to keep the core body warm, heat packs, gloves, mittens, buy those little heat packs from Sam's Club and keep them handy in your pockets. Vasodilators, so sometimes there's topical creams or gels you can use in more kind of urgencies, but then there's oral medications that are usually blood pressure dropping medications that we use. There's some IV medicines in kind of more urgent situations we use as well. For the GI involvement, a lot of the time these patients are going to be on antacids or sometimes pro-motility agents for the reasons I mentioned. If they have small bowel involvement that's significant, it can change the microbiota flora, so sometimes they're on rotating antibiotics. The most simple thing you can do if your kid has significant reflux from, or even any reflux from systemic sclerosis, is actually just raise the head of the bed, get risers and put the head of the bed on there. That makes a huge difference, not just like stacking 2 or 3 pillows, but actually the whole angle of the bed, because you're using gravity in your favor. Limit the food before sleep, small meals, easy to swallow, protein shakes to get those calories on. Dinesh Khanna through the Scleroderma Foundation has an excellent PowerPoint that you can find just by easily Googling. I think it was like his 2017 talk or whatnot, but he focuses on these like things that you can do. And there's a nutritionist that has a similar talk as well through the Scleroderma Foundation that I share with my patients about this. Systemic medications, again, there's like a whole laundry list, but they're similar to the ones I mentioned for localized, but they're directed towards organ involvement. So if they have interstitial lung disease, there's certain treatments. If they would have pulmonary arterial hypertension, those are certain treatments. So you're treating more of that organ that's affected. Next slide. And I'm up at the hour time, so I'm just going to go maybe just 5 minutes over because this is just the super brief updates on therapy and research. So this is just to show you it takes a group of people. I have a big registry and I do a lot of research, but I do a lot of collaborating. I might be, one of the PIs or a co-PI, but it takes a lot of collaboration. This is a rare disease, so we work really well as a team. So the top is pediatric rheumatology collaborators in the U.S. and in Canada that came together. We kind of validated some skin scoring measurements, but we did a recent study within CARA to look at methotrexate with IV versus methotrexate with oral steroids, just to see IV versus oral steroids for treating localized scleroderma that's active. And in the end, we found that they're not significantly different. So it's okay if Dr. X on the East Coast treats with IV steroids and methotrexate, and Dr. Y on the West Coast treats with oral steroids. So it showed that they're equivalent. So that's good because that is some concern sometimes. And then another collaboration on the bottom is with Europe and the UK. We're helping them develop a CellCept versus methotrexate protocol. We believe they're probably similarly effective. We also want to see, the main thing is the tolerability. As you guys, if you have kids on the phone, know that methotrexate sometimes is not the best tolerated with some nausea and fatigue, etc. So we're seeing if MMF is just as equivalent in treating the disease, that might be a nice alternative if there's less side effects. Next slide. And then SCORE or CARA study, I've kind of advertised this at the Scleroderma Foundation meetings before because this is actually through a Scleroderma Foundation grant. It's called Identifying Juvenile Scleroderma Immunophenotypes. So the goal of this is to use the CARA and Scleroderma Foundation infrastructure to get both clinical data and blood from juvenile localized scleroderma patients that have active disease that are about to start treatment, and then follow them over 2 years, collecting blood and clinical data every 6 months, And the same thing with systemic scleroderma patients, but those systemic scleroderma patients can be active or inactive. It's so rare. We just want to get anyone we can get and get their blood, et cetera. And we're trying to see, you know, over time how the immune system changes and how it's different from healthy controls, et cetera. Next slide, please. So these are just the main players. You know, myself, Dr. Lee, and Ann Stevens, we kind of wrote the grant a while ago, but it's finally enrolling patients. It just took a little while for some regulatory things, and Kelly's from CARA, who's helping organize this as well. Next slide. And this is just a map of the 18 sites. Some of this has mildly changed in the last 6 months or so, but it's pretty much accurate. So, you know, I'm the biorepository, so I get all the blood from these places, but all of these places have pediatric rheumatologists that are recruiting patients and sending clinical data into like a unified database that's de-identified and with the blood samples too. Next slide. And you can hit the next button because it explains. Keep going, one more. Okay. So basically we're collecting all these things. We're collecting their clinical data, including quality of life, how this impacts the patient, et cetera. But, you know, we're also collecting this biological data. So, you know, I run cytokine profiles, some cellular phenotype. I work with some antibody profiles with Mark Fritzler and some other folks. We do some RNA sequencing. So we're trying to see how the immune system changes over time in these patients, you know, with or without treatment, with different clinical features. Next slide, it will kind of explain a little bit more. And you can hit like 1 or 2 more times. Yeah, that's good. So what I'm trying to do is take all these things that we're collecting and then put them together and find certain markers. I'm guessing a group of these clinical and research things together will be clues to, okay, this patient has very active disease, or this patient will have resistant disease against methotrexate, or responsive disease, or these people are going to be the one that relapse. So that's what we're trying to figure out. So that's why we're collecting all this data. And in tandem, while we're collecting this data, if the patients are enrolled and they have localized scleroderma and they're going to be on methotrexate or CellCept anyway, we're asking the clinicians to kind of just follow this consensus treatment plan that we developed in the prior CARA study. That's what that is for. Next slide. And this is just the contact for that. Hopefully you're near or at a center that was on the map. If you have questions, my coordinators, the primary contact, Kayla Schaller-Fitch, the easiest way to email is at scleroderma@chp.edu. Next slide. And then what about genetics? How is that contributing? Obviously, you guys probably have like gathered from over time that this is not very hereditary driven. It's not like grandmom has systemic scleroderma, mom has it, and the child has it. There's usually a smattering of autoimmune disease in the family, but it's a mix of lupus or Crohn's disease or psoriasis, etc. But we're wondering in those kids that have really early onset disease, is there a genetic component? So I'm working with Ann Stevens and the NIH with the Scleroderma Research Foundation to answer some of these questions. Next slide. So we're doing what's called whole exome sequencing, so look at the part of the genome that's expressed into proteins and seeing what's different between the affected child and then the mom and the dad. So that's called a triad or a trio. So we're recruiting any patients with juvenile systemic sclerosis because it's so rare, and then we've opened this to juvenile localized scleroderma patients that have a young age of onset, or they have a unique family history, like 2 siblings with localized scleroderma or something like that. Again, the contact information is the same, that's scleroderma@chp.edu, but we're just starting to get some data. It will be interesting, so hang tight. It will probably be a year or 2 until we have some targets, but this is it's not to identify the scleroderma gene, it's to identify what in the immune system is different from the affected child versus their parent, but then compare that against like 30 or so affected children, what's different from their parents, and try to find the immune genes that are up or down regulated to see what part of the pathway we should focus on. Next slide. And then medications besides methotrexate and MMF for pediatric scleroderma. Next slide. So this is the CARA meeting. It's an annual meeting where the peds, rheumatologists, and dermatologists come together. And what was interesting is that if you look at the poll, everyone was using methotrexate and CELSIP relatively equivalently. And most people are using steroids, as I mentioned before, whether it's oral or IV. The IV just dropped off. That's the red bar. And what's really interesting is that a fair amount are also using those biologic agents I mentioned, tocilizumab and abatacept. About 42% have used some type of biologic on patients with the localized scleroderma. So we're very interested in starting some clinical research and trials in that. Next slide. So these are the ones I was mentioning, the new kids on the block for both localized and systemic scleroderma. So abatacept or Orencia, it's approved for juvenile idiopathic arthritis, so that's why I think it's getting slightly easier to get approved by insurance for juvenile localized scleroderma that has like the joint involvement. Systemic scleroderma is looked at in adults. They're starting to do early trials, like phase 2 trials. It's showing a great safety profile. It's unclear if it's making too much of an impact, but the MMF that popped up later. But it is showing, so not Orencia, but I put that in the wrong spot. I apologize. But MMF or CELSIP in adults is showing actually nice response in the skin score going down. So we're using that more. That kind of popped up here on the slide, so I apologize. But that's just an example of some of the biologics. The Actemra that's later on the slide, tocilizumab, that is, there's a case report that I just attached. There's 11 juvenile localized scleroderma patients in Europe that they published that were failing methotrexate and CELSIP and did respond to the Actemra, which is great. In an adult scleroderma world, it's a phase 3 trial right now, and it's showing that it preserved lung function. So that's the graph on the bottom. You can see the FVC in red is stable. That's what you want. 48 months, that's 4 years, I believe that maybe that's 48 weeks, excuse me. So 48 weeks out, the FVC is stable. It did not drop, whereas placebo, which is standard of care, actually the lung function dropped. So it looks like it's preserving lung function in adult systemic sclerosis, which is great. And then the localized scleroderma, it looks like it's helpful for the refractory cases. So more to come on these guys. These are kind of relatively newer case reports. Next slide. And then brand new, we're being one of the sites, we're kind of going through the IRB process, is nintedanib. This was just approved for adult systemic sclerosis for ILD and pulmonary arterial hypertension. So we're about to pilot it in pediatric interstitial lung disease of any variety. So it could be from ILD from dermatomyositis or systemic juvenile arthritis or scleroderma. It's targeting some vascular molecules, so it's kind of different from our other medicines. And then for patients with very aggressive disease or sometimes refractory disease, stem cell transplant are becoming opportunities in certain locations. Again, for systemic sclerosis, rarely, but for some of the very, very severe types of localized scleroderma as well. I think that is the end. Yay, because I have no voice left. But this is the Kids Get Scleroderma 2 conference that I organized with Suzanne Lee and Ann Stevens a couple years ago in Hackensack, New Jersey. We had one in Denver, Colorado, and we're hoping to organize another one again. Right now we're partnering with the annual Scleroderma Foundation meeting and having the pediatric Kids Get Scleroderma 2 part of that, but we're hoping to have an individual meeting again too, because that was a lot of fun. Kids can be kids and learn some things about their disease too. Next slide, I think it's just a thank you slide, and then that's the end. Yep, that's the end. So that's just contact information and things of that nature, my study team, but thanks, mostly for some of the things I presented, for, my patients, their stories, also research. We wouldn't be where we are if I wasn't able to get some of those patient samples and things, so I wanted to thank patients too, and then lots and lots of collaborators and funding. Hopefully keep moving the field forward.
Wow,
That is it.
doctor, what a heck of a presentation, and thank you very much. Michael, you're unmuted now too. I just want to say thank you first before I open it up for questions from the group, and then what we'll do is that we'll try to answer it. Now, remember that the doctor today can answer some of your questions, but is not going to be able to recommend drugs and stuff like that for you. So let's just remember that is that today is to try to gain some better education for what is going on. So I'm going to unmute everybody now.
It sounds like your doctor.
So if you have questions, please bring them up.
Can you guys hear me?
Yes, we can.
Oh gosh, okay. So I was curious because my daughter struggles obviously with the low BMI and appetite stimulation, getting full really easily with the gastric side effects. And so I wondered, we've tried a lot of different medications, but I wondered what the thoughts were on CBD oil. I know there was a discussion, I guess, about it with adults at the last conference, but I don't know if it was discussed because we weren't there. I don't know if it was discussed in using children, like to help with appetite or just curbing like inflammation. Like I don't know what it's in CBD oil with THC or without it.
Yeah, so I would refer to the PharmD pharmacist that's on the Scleroderma Foundation panel. That she's probably the one that gave the talk. She's awesome. She's won that award. Her name is blanking me. I'll think about it in a minute. But she did give a talk, and I believe it was
Jessica Farrow.
Yeah, was it recorded?
Albany. Yeah, that's one of the. Yes, it's recorded this year.
Okay.
Thank
I
you,
mean,
Bruce.
I talked to her. We're both on the board. So, I mean, I talked to her, and not that I saw her presentation, I want to, but, she was kind of giving me the overview, and the same would apply to kids. It's kind of like it's an unknown, may not help. It may hurt if it's, I mean, they sell these at the drugstore that's like around the corner from me. There may be contaminants in there. It's in kids in general for any of our autoimmune diseases like juvenile arthritis, things like that. We are not promoting it at all. If it helps, I don't know so. I don't see any hard evidence that it's doing that. I think it's honestly a fad, to be honest. It's making a lot of money, but that's my personal opinion. I would defer to Jessica Farrell's talk. And if you're, in general with the GI motility issues, general medicines like the pro-motility agents, periactin can help appetite stimulation, things like that, but really needs to be hooked up with a good peds GI specialist. And there's peds GI motility specialists. There's only a few in the nation. Those are really, we're seeing if there's significant GI issues. Honestly, they're going to be able to help more than I can as a rheumatologist.
Are there any in California? Are there any of these motility doctors in California?
There's one in Seattle. There's one in Seattle. I don't know about California. And her name is really long. It's with the A. Ambarts. It's Luzine Ambarts. It's really long. It's like AMBURTSAYN. But Lucine is her first name, and she's in Seattle. She's with their GI. She's doing one of these studies on quality of life and GI with us in systemic scleroderma.
Okay. Do we have any other questions for the doctor?
I do. I'm interested in the genetic piece of it. I'm in a mom's group where you hear that there's multiple siblings that have scleroderma, and I know with my own son, we recently learned, we knew that we had, my father has a cousin with scleroderma diffuse, and then we found out that he had another cousin with scleroderma. So the genetic piece, I mean, you don't hear much about people having scleroderma. To have three relatives, living relatives at the same time that have it, I just found that to be, I don't want to say interesting because it's not interesting at all, but I just wonder how there couldn't be a genetic connection.
Oh, yeah, that's why we're spending money to do the study. So we think there's some link. It's just not strong. It's not like cystic fibrosis. You have the gene, you have the disease. Or Huntington's, where it's autosomal dominant. It's more of a mix of things. So it's probably a mix of the immune system being altered over time and environmental exposure, in addition to some genetic background. So there's definitely some genetic background. I mean, I think I've passed it briefly on the slide, but there is a family history of probably about 70% of our patients have some family history of autoimmune disease at first relative, such as like a mom with psoriasis and an aunt with autoimmune thyroid disease. So there's a clustering. Now, to have some form of scleroderma within one family in multiple relatives, that's unusual. So and yeah, there's some genetic predisposition is what I would say. And what we're trying to find out with the genetic studies is like what's altered in the immune system. So I don't think we're going to find a gene. I think we're going to find a group of genes that regulate a T cell or something like that. And that will be like, oh, it's the immune system, the genes that are usually on or turned on to regulate the T cell regulatory, proteins. They're up or down, they're off. That's what we're trying to find out from this is like what in the genetics is like having some impact on the immune system that's making it different in these children. So I think it'll give us clues. I don't think it'll be like a particular gene, but yeah, there is some genetic predisposition of them.
Okay, thank you. Is there any other questions?
Yes, can you hear me?
Yes, we can hear you, Diane.
Okay, great. Hi. I had a question regarding the biologic information. I don't know much about it. Can you just kind of help me understand why it's different and what would be a good way to look into that?
So the biologics is a big term for anything that is developed more specifically against a particular protein or cytokine, we might call them. For example, tocilizumab or Actemra is specifically an antibody built against this inflammatory marker IL-6 or interleukin 6. The one that you all would probably know is Humira, is that golfer, the commercial of the golfer, and he has psoriatic arthritis and he takes Humira and now he's doing great. That Humira is commonly used in rheumatoid arthritis and juvenile arthritis. That's an antibody developed against TNF alpha, a protein, an inflammatory protein called TNF alpha. So these biologic agents have been really groundbreaking in juvenile arthritis and adult arthritis. I mean, patients do pretty well with methotrexate, but I mean, some of them really need these biologics. Their arthritis is gone. They're doing wonderful. So anytime something's working in juvenile arthritis or rheumatoid arthritis, we tend to spill that over into our other diseases like lupus or dermatomyositis or scleroderma that are more rare. So that's why we're starting to use these, because we have some evidence that they're safe in juvenile arthritis and they're effective in juvenile arthritis. Their exact role and how they're working, we're investigating that. But these things that I showed you were what we call case reports. So it's like 2 or 3 cases you get together and you publish because you said, hey, it worked in these patients. Maybe this is an idea if the kind of standard therapy is not working, or maybe it's a new idea for therapy. So that's what's biologic.
Okay, that's a lot of information. I'm going to have to do some research to catch up. I did want to ask, are biologics considered a or item or an and item? Meaning, is this something that if the patient's then a biologic would be added in, or it would be a replacement for those types of treatments?
It depends. We don't know that answer yet in juvenile arthritis, to tell you the truth. Like we have what we call CTPs, starting a kid with arthritis on methotrexate alone, starting them on methotrexate with Humira, starting them on Humira alone. So those are studies ongoing right now. So it depends on the patient. Sometimes you add the agent on if it's severe and it's not responding. Sometimes you'll just start with a biologic, but but we don't know those answers yet, and we're trying to find those out first in juvenile arthritis because it's more common.
Okay, thank you. And thanks for doing the talk this evening. This is very informative.
Yeah, no problem.
Thank you. Is there any other questions?
Those.
There's a lot, I know. I try to cut it down. This is cut down from my original, but it's still a lot.
It's great. Thank you.
Oh, I have a
I
question.
have a question. This is Tanya Willis.
Go ahead, Tanya.
We have seen you in Pittsburg, doctor, and I have a question. My daughter is on methotrexate and was on the mycophenolate, and then we added in Orencia to treat her. She has the localized scleroderma and the juvenile rheumatoid arthritis. And so I'm wondering if you have any patients on that combination of medication, and if you have also seen oral leukoplakia develop.
No to the oral leukoplakia besides you. And but yes,
my daughter had that develop, and we're all like, nobody can figure out if it's because of the combination of those medications.
no, I mean, I remember that's why I said no one besides her for the oral plakia, but the methotrexate MMF Orencia, yes, Dr. Lee and I actually are going to publish. We have 12 cases between her, myself, and Egla Rabonovich, and at least a third of them, so at least 4, maybe 5, are on that combination. And no, I have not seen the oral.
And no one else. Okay, because the oral pathologist has only seen 2 others with that, but not on those medications. So we're just curious if this is a common thing that happens with these medications, or not.
Not so much. Nope.
Okay.
You're the end of one.
All right, I'm going to say thank you. I'm going to respect the doctor's time, and I'm going to cut that as being the last question for the evening. Now, Michael, would you like to give some closing remarks since you are now unmuted?
Can you hear me?
Yes, I can, Michael.
Oh my goodness. I don't know what happened, but my pets enjoyed the introduction very well. They said I did a very good job, so sorry about that. This was the 5th webinar in a series and focused on managing the needs of pediatric scleroderma patients. There will be one more webinar presented in 2019, and you can locate the information about them on the Michigan Chapter's website. The Michigan Chapter's website is, all in small letters, scleroderma.org/Michigan, and Michigan is spelled out. We would like to thank Dr. Torok for presenting today for the Scleroderma Foundation. I know this information has been very beneficial for us all. I am sure we will have many questions and many questions more, but we've obviously run out of time.
Just for once, for everyone who's been on here or wanted to share this information, it is being recorded, and there will be a link on our website in the next few days. So if you want to go back and look at some of this information a little bit more in detail, that will be available for you also.
Okay.
Good.
The next webinar will be for scleroderma patients who are more newly diagnosed in the first few years of learning about how scleroderma affects our lives. Dr. Amber Young will be presenting on the topic Scleroderma 101, the first 2 years of diagnosis. This and other formative information live webinar will be on December 12th. Once again, thank you, Dr. Torok, and I'm sorry about the introduction. I appreciate your commenting about Dr. Khanna. He is my rheumatologist. I am a scleroderma patient. I was diagnosed at the age of 55. I am now 62, but just an interesting point is I've talked to many people who have had scleroderma like myself, and we also had juvenile shingles. We all had chickenpox, went right into shingles. So we had compromised immune systems that kind of led us to where we're at. But thank you very much. Your presentation was awesome. Thank you.
Thank
No
you.
problem. Bye-bye.
Bye-bye. Thank you all.
Bye.
Bye.